Careers in Emergency Medicine. In particular, today we're going to look at leadership, research, quality assurance, and other paths for careers in emergency medicine operations. I'm Josh Joseph. I'm the Director of Network Operations for Beth Israel Deaconess Medical Center and Assistant Professor of Emergency Medicine at Harvard Medical School. I have no commercial disclosures. So, for the overview, we have many different career paths within operations. The one that everybody has immediately come to mind is that of clinical leadership. Most community EDs have a medical director. Comparatively, academic EDs often have multiple positions in operations depending on the size of the department. This may be a medical director, and possibly an assistant medical director, even an associate medical director, and often there is a vice chair for operations or other top-level administrative position doing operations. Now, what does a medical director do? There's no single answer, and it depends considerably on the size of the practice as well as the practice environment, and that involves whether this is a independent group, a corporate group, a hospital-employed group. There are a lot of variables at play. But fundamentally, most medical directors are involved at a minimum in credentialing. At a smaller institution, this will also encompass hiring and interviewing new staff, scheduling staff, doing QA reviews, whether regularly or on an ad hoc basis, participating in quality committees such as an ACS and stroke committee, deriving clinical policies and guidelines for the department to determine standards of practice, and potentially participating in an expanded role in hospital administration. Now, who is a medical director can depend a lot. For a small democratic practice, being medical director may not be seen as a huge honor. In fact, it may be seen more as a responsibility, and it may actually rotate between individual physicians within the group. Larger groups, hospital-employed groups, often have a much more substantive medical director position, and this may come with either a significant buy-down in terms of time or additional salary support, depending on the model by which physicians are compensated in the group. Oftentimes, this is not necessarily a position that everybody is gunning for, and somebody straight out of fellowship may be able to become medical director. In academics, it's a little bit different. In larger settings, duties are often bifurcated between the medical director and the operations vice chair, or whatever the administrative position is called. Typically, the medical director will manage day-to-day operations. This involves scheduling, coordinating with nursing leadership, a lot of the nitty-gritty that helps the ED run on a daily basis. Comparatively, the vice chair, or again, whatever we'll call this position, often sets longer-term strategy for a department. Often this person is involved in clinical pathway development, will commonly meet with their counterparts in other departments such as medicine or neurology, and is often involved in recruiting and overall staffing for the emergency department, if not necessarily the day-to-day schedule. Again, your department may vary considerably. There's an entirely separate track often taken in operations, although even though it's considered separate, at smaller institutions, this can blend a lot with the medical director's role, and that's that of the QI director. Primarily, a QI director is tasked with reviewing all of the many quality criteria the department, and as part of a larger hospital group, the department needs to report to the government, to Medicare, and to other insurance services. These are a big deal, not only because some of them certainly are serious markers of quality and how well a department is functioning, such as its stored EKG time, but they can also significantly affect the resources and pay provided to your department. Often the QI director will direct a multidisciplinary QA committee, and this depends a lot on the size of the department. For a large department, this may involve many different physicians, some of whom may be permanent QA committee members, some of whom may be rotating through, and often engage in a regular case review. For a smaller department, the QI director may actually be involved in triaging all of the QA cases that come across their desk. And very commonly in larger institutions, the QI director will coordinate with counterparts from other departments. Research is another track that can be separate but can also be melded with a leadership role. There are few institutions where there is a formal research director of operations, although this practice is becoming more common. More commonly, at institutions that have more than one medical operations position, either an independent faculty member will make operations the focus of their research, or it will be part of the portfolio of the medical director or vice chair. Often in that case, these individuals are supported either by somebody with a stronger primary research background or a statistician. One of the reasons why this has not historically been as big of a role for operations is that grant support is really hard to come by. It's certainly getting better than it has been in previous years, and generally researchers within operations tend to focus their support from the AHRQ or ARC for quality outcomes. However, even with respect to this, it's often very hard to propose a grant for an operations study. To an emergency physician, saying that you're going to improve throughput for every patient by 3 to 5 minutes is a really big deal when you consider the number of patients who come through an average department. However, that's not exactly an appealing topic for many government granting agencies. Instead, a lot of success has been achieved by using individual diseases and looking at operational outcomes within them. For instance, for patients with ACS, trying to have an operational intervention that will improve the door to EKG or door to balloon time. Or alternatively, for patients with stroke, ensuring that other quality measures, such as the EKG or imaging times, are provided within a specific window, often will be met with much greater success than a purely operational metric. There are other paths to a career in emergency department operations, and again, this is not necessarily a mutually exclusive route. Depending on the structure of your practice, whether you're hospital employed or independently employed, there may be multiple opportunities for you to get involved with hospital leadership. For hospital employed physicians, often there is a path directly from the clinical role to join administrative staff, and this, depending on the time commitment, may be something that you can do simultaneously. It's certainly the case that for many emergency physicians, the when you're on, you're on, when you're off structure of our work is very conducive toward these positions. Alternatively, even when you're not in a hospital employed group, often there are chances to get roles within medical staff leadership, and at larger hospitals, this can come with a significant compensation for your time. Finally, there's an increasing role for emergency physicians within consulting and industry. Emergency physicians with operational experience and knowledge can be of incredible use, in particular to risk management practices, because ultimately, when we improve the quality delivered by the emergency department, we are safer in our practice. And many of these organizations are looking for that individual expertise that people with emergency department operations experience have. There's also an increasing role to get involved in healthcare technology startups, and also within managed care.